I have many questions on the health, but I want to ask about the social work because it's a bit interesting for me. One like informative question, and the other one is a point which I want to raise, maybe for our joint discussion. About the PCRC, the rehabilitation centers, I wonder, is it not correctable in a very simple way? I mean, as far as I understood, they have an incentive to get more people into the rehabilitation centers. Is it not an outsourcing that can be just, mended in a very simple way, just fixing the incentives? That's one question. The other one is a bit of an issue that I want to raise, comparing what you said about the criticism that you and others were talking about the projects of caregivers, the women caregivers inside the family, and I want to raise a question here or a point. In Israel, there is, as someone David mentioned, we don't have an elderly social security. We don't have an elderly care being, totally arranged for. And one of the possibilities that we do have right now, and this is one of the options that the reformers were raising, is that women inside, especially women in the Arab sector and the ultra-Orthodox, which we talked about their difficulties to move to the market, to the labor market, giving them the opportunity to take care of the elderly care and giving them a special allowance through the Social Security, which sounds a bit like the political, the idea that you mentioned, but it doesn't come from any Orthodox or any religious thinking. It's just a matter of, it's just an idea, maybe a good idea, that people had in Israel to combine the two causes. One, that we want elderly care to be given. The other, women like in their 50s and 40s, which do not have the possibility to go to the labor market, and they get this allowance. Now, I understand that in Turkey, it's also a political issue, and it stops women from going to the labor market. And these issues were also raised in Israel. For example, people said that it is being used in some families. There were investigations, and they found that it is being used in a way that like cheating the government in some ways. Yeah, misuse by some. But I want to raise the question: can we not, both of us, all of us, can we not find a golden route here that will somehow combine the good causes? The cause for women to go to work, but they cannot go to the labor market. The cause of care inside the family, and this is without me being any conservative, politician, just wanting a golden route.
All right. So for elderly care, I'm a little bit critical about elderly care at home. I think it's nice, first of all, when somebody decides to take care of his, her mother, whatever. Family member. In Germany, we have the same discussion. It's huge. I mean, of course, you have women there who really like to help at home, right? And they say, yeah, I'm 12 hours a day or even more. I'm taking care of my old mother, so it has to be compensated somehow. And the state is doing that. But critical points are, first, here we live in societies, or Turkey is somehow a society where even the woman sometimes can't decide by herself if she wants to do that or not. The husband says you have to do it, so she has to do it, right? That's the first point. So the first point is it needs to come from the person who takes care of the elderly by themselves. There must be an agreement to this. Secondly, I'm not really sure about the degree of disability, for example. Even if the elderly is lying in bed, it's a 24-hour job. You can't do that at home. The woman is going crazy. Then it leads to depression, then it leads to frustration whatsoever. So until a certain point, until a certain grade, it's fully okay to feed the woman or whatever to elderly. But if it comes to a 24 hours, 7 days a week job, then the society should think about something else. And the third point is training. Some people at home are not even trained to basically respond to situations that may occur, right? If the woman or the woman, man that you take care of has an emergency, how do you react? Or in a certain situation, the care at home is not good for the person. For example, we know in Germany, a person can't lie on his or her back for a couple of hours. Every 4 hours you have to turn them around, otherwise they get sore in the back, etc. So this kind of knowledge has to be given. In Germany we have, for example, trainings on that, which is like 3-4 days, and then they try to basically make up that. Anyway, Mike.
Is it the migrants in Israel? It became a migrant worker.
Yeah, no. I mean, there are certain migrants in that jobs, but not that many at the moment. But there is a need for jobs like this. Anyway, my questions actually, 2 of them. First, the strokes have struck me, like the number of strokes that you mentioned, and the people dying from a stroke. Is it? But are there not any other factors coming in? For example, response time, right? I mean, even my grandmother died because her partner in life didn't respond for 3 hours. She had a stroke, she was sitting there in her armchair, 3 hours later she was dead. But he didn't do anything because he couldn't see the signs of a stroke. So even now in Germany, a lot of, there's lots of education how you can identify strokes and stuff like this, and even you get some tasks that you can do with the ill person, so to figure out what they have. Anyway, I just want to not go into detail, but or for example, when is the ambulance arriving? Is there a traffic jam in town? Can you reach the hospital on time? All those kind of factors are also important. And the last question, you said 630 million visits to physicians per year in 2013, which is an extraordinary number. But I'm wondering, with all the figures that you gave, with even the hospitals that have been opened and stuff like this, isn't that also because of the health tourism that Turkey is facing? I mean, there are a lot of people coming from outside, then visiting dentists. You have this hair transplants. You see all these men with the transplanted hairs and eye operations and stuff like this. Is that a factor that comes into the statistics? That's the question.
Thank you. Yeah. And then you. Yeah.
Thank you for this very extensive presentations for both presenters. It was really very illuminating. My special question is for Kayan. You have presented us the critical view of anatomy of this Turkish health system, but could you elaborate more on the feelings of the beneficiaries more? Because so far we know that it's the basic factor that strengthened the votes for the governing party today, at least until some point, until 2000, towards the end of the decade. So the people were happy because of this health reform. Do you have a data how their feelings have changed, or are they still happy? And for the elderly care issue, I want to add some things after Burcu, because she will be answering it, but I have things to add to that too, probably. Not to finish up the time.
Yeah, the next one. Thank you.
Thank you very much. My name is Özgür Gürbüz from Turkey as well. My question is to Dr. Kayan too. Is there any international standards? I know there is no legislation, but just like for a doctor to see like a limited number of patients in a day. My brother is a dentist, and then when he was working for the state in the Kurdish region, he like some days he was seeing more than 100 patients a day. And then what he was doing, basically just putting one patient in a chair and then giving the injection and then looking after the other one. Mostly he was saying, I have to remove the tooth because I don't have any more time. So, because they want him to look after the patients. So they only care about numbers. Is there any kind of international standards for that? Because it's getting really serious in Turkey, I think.
Yeah, I think, thank you very much for all questions. I think this time, this much question, we had 3 or 4, I think, anyway. So let our speakers answer those, and then we can make another turn also. Can we begin by you, please, with your permission?
First, Rami's question about protection, care, and rehabilitation center. It's not the rehabilitation center servicing the disabled, but it's a specific center servicing young women, young girls below the age of 18 who are victims of abuse. So you see pregnant youngsters there and so on and so forth. So they are put there with this child protection legislation, and state is just offering some kind of a protective type of service there. But even we see that the emergence of the abuse and violence problems have elevated in the last decade, we don't see any kind of an expansion of capacity. That was I was referring to. So it's all state provided, and it's all run by the state legislation, but there is a very strong capacity problem in the sense that these are the centers that run 7-day, 24 hours, that kind of a full-time type of care centers. So the social workers are, they're employed, they're working on shifts, but they do have serious problems, especially in relation to the abusing parent or brother who keeps on, even if there is the court decision, they keep on, trying to run away with the girl and so on and so forth. They do have that kind of intrinsic problems which are not related to the private domain, so it's all state-related issue. And also for the rehabilitation centers, the private ones, they don't have any capacity problems. There is excess capacity already there. So the intrinsic motivation towards opening up new centers have proliferated the number of centers there, which are running sometimes almost with no patients there, but the list of patients by which they get the subsidy from the state. So there is a kind of a problem there. And to your comment about the cash for care allowance, I totally agree with what Daniela have raised about, because it's a matter of choice. It should be a matter of choice, first of all, because women has to have a freedom of choice in terms of giving the care or not. It could be something emotional that she wants to do, or it could be something that binds her, with all sorts of relative relations and others. So I feel as if without providing that kind of a choice option, we cannot even talk about a golden rule. So, so apparently, thinking about the migrant care workers, so we have the, for instance, former USSR country type of caregivers recently. So we have the migrant care workers, women care workers who are employed in middle-income households, taking care of elderly and disabled there. But I still tend to see it as a kind of a very problematic from a gender point of view, just strengthening that the patriarchal role that is, burdening the women. So there might be some kind of a choice. And of course, there is no professional training that is involved in it. So even if you are hiring, for instance, a migrant worker taking care of your elderly, you have no idea whether she has that professional training, whether she knows what to do in case of signs of stroke and so on and so forth, so which might be a serious problem in terms of the quality of care. So I think this is the questions that I have to raise, but I would just like to thank both of you for your questions and comments.
Yeah, please. Dr. Kayhan.
Yeah. First question is, maybe possible any other factors impact that from stroke. I don't think so, because it is measured same way all other countries among OECD. But maybe we can investigate deeply later. Second one is over 630 million visits last year. Yeah, it does not include health tourists yet. Yeah. According to non-official data, last year approximately we had 1 million patients from outside as a health tourist. But 2 or more years later, maybe it will be included. And some beneficiaries related with health transformation program, especially patient satisfaction. Yes, you are very true, because patient satisfaction rate has increased to 71% in 2013 from 37% in 2002. And last question is related with physician and patient rate. In international standards, for example, according to WHO, per physician medical examination per day, maximum 30 patients, not exceed over 30. Yeah.
Is there any warning from WHO to Turkey?
No, because WHO support our neoliberal health policy, unfortunately.
Yeah, sorry,
World
before
Bank,
take,
IMF, and other institutions.
before taking some more questions, we can do it later, but before that, Dr. Yakut Çakar should add something. Please
I would like to also add to the question raised by Yelda as well, you know, thinking about patient satisfaction. It's very much related to the pre-reform era, you know. Before the reform, some segments of the society, especially the poor individuals who are now covered by the social state insurance, did not have any access to the university hospitals at all. So it brought about some kind of an leverage to their service perception. So even if the quality of the service is deteriorating in terms of the times, the minutes that the physician is allocating to the patient, it becomes a matter of concern that they tend to evaluate the service in terms of their access. So they say that now I can go to the private hospital, now I can go to the university hospital, and I have the right to choose the doctor. So that's how it's also advertised by the government as well. You know, they use this. You know, the freedom of choice of the physician is one of the advertising campaigns that the current government is also using. So. So it's interesting. So satisfaction, you know, I'm a person that is very much curious and a little bit skeptical about the satisfaction concept in general. So how satisfied an individual from a service is something that is very subjective, and it very much relates to the comparison point. So if the poor individuals are comparing to their pre-reform period, of course they're 100% satisfied with what they receive now, even if they have to make some kind of co-payments and, you know, any kind of extra payments out of their pockets, but they see that they now have the access. So that's, I'm sorry, I'd like to add for it.
For your comment. It's clear that patient satisfaction is not related with only quality of care. It is independent.
Yeah, at least they can see the professor anyway. Yeah,
yeah, exactly. That's what I meant.
Please. Yeah.
We've heard about the family-oriented policy of taking care at home and home care. Now, my question is regarding the profession of the social worker in Turkey. Is it a typical, let's say, profession for women? What is the image in the population of social workers? And
image of social workers in terms of general population. So how do general population
how is it
perceive
received? Because maybe I'm wrong, but if we have here the doctor and the medical doctor, and we have a social worker, at least in Israel, well, I would say the image. I'm only talking now about image. I'm not talking about salary, because there are huge differences between public and private and so on and so on. But well, the doctors, the medical doctors have a high image, I would say. Social workers, I think, unfortunately, less. The second thing I want to say, in Israel, for example, and colleagues may correct me, but still most social workers are women, 90% even, yeah? Most teachers are women, most nurses are women, and so on. And this is also the professions on the salary level less paid. So I would like to know how is this in Turkey? Thank you.
So I think, is there any, one more, because the time is running up, so just one more question. Sorry about that. Yeah.
Just follow up on Mickey's question. Let's see if this works. There we are. So thank you very much. There's just so much to pick up on, and we'll have to pick on some of them over dinner, I guess.
Sure.
But one quick technical question, perhaps even, with regards to social work. I've done a bit of work on it, and Onen has, who's not here at the moment, has done some work on it as well, the care homes, etc. Can I ask, if you know, it's a bit technical, so maybe you haven't come across it, what the pay arrangement is with the private homes? So are they basically paid on the basis of a bed, so when the bed is full? Because I looked into it, and it affects how social workers behave in Israel, right? They fill up the homes, or they want people out. There's been study about that since the 17th century in poor laws. In workhouses in Britain, and it's kind of the same type of arrangement, and it affects behavior. And just to follow up, not to steal my own thunder for tomorrow's presentation too much, but Mickey's point about this being very gendered occupation, welfare, social services, nursing, and teaching. In that order, these are the services that are most privatized in Israel. So the more they're gendered, the more they tend to be privatized in Israel. This is if you want to hear more, come tomorrow afternoon. Okay. But I'm just wondering if there's something similar in Turkey.
Yeah, please go ahead.
Privatized or contract? Outsourced. Yeah, outsourced.
Outsourced. Yeah. Well, the answer is, please, very, very short.
Very brief, okay. Just go in detail over the dinner. In terms of professionalization of the social work in the Turkish context, the thing is, social work profession is very young in the Turkish context. So it just emerged in the aftermath of the Second World War, especially with the UN's efforts, indeed. So, and it was dominated by a single school up to early 2000s, which means that, and in the early 2000s, we were talking about scarcity of social workers. And now there is the proliferation of the schools of health and schools of social work everywhere. And also the state started to respond to these, criticisms towards lack of professionals by increasing the amount of public placements, you know, as social workers. So ultimately now, in the last 5 years or so, social work profession became some kind of a state employment guarantee, and especially thinking about youngsters who are just making that kind of choices in terms of the colleges that they would be attending. We cannot talk about, so the School of Social Work enrolled the same number of male and female students, so they had the quota for over the years. But recently, since this became a kind of a very guaranteed employment placement for the young people, it became a matter of concern that we have mixed classes. So I teach at the Department of Social Work, and I see almost equal numbers of male and female students. So there is, you know, looking at the profession from that point of view, we cannot say that it's gendered just because the School of Social Work was organized to have special quotas, the same quotas of male and female students, so that's why it emerged. And apparently in terms of pay arrangements, especially in private homes, social workers on contracts, and these contracts are in general made, you know, with low payment schemes when compared to the state pay schemes. So people, you know, social work professionals try to be employed at state, and state opens up placement, public employment placements at very pre-announced times of the year. So whenever these times do not correspond with the graduates, so what they do is they engage into private agreements with lower wages up until they are appointed to a state position. So private nursing homes do have very high rates of turnover in terms of their social worker and employment. So we can continue over the dinner. So I'm sorry I've kept it very long, but there are too much to discuss.
Thank you very much. I would like to thank Professor Kayhan Pala and Dr. Burcu Yakut for the presentations, and thank all of you for your contribution and your questions. So good evening. I think, yeah, Dr. Burcu Çakar, students would find time to have their dinners.